We shall now go on to our next speaker, Dr. Shishir Agrawal, a brilliant surgeon with quite an educative career in the sense, as I read through it, he's an anterior segment man with a fellowship in vitreoretina, like some more of us here. Chief surgeon of the Agrawal Eye Hospital at Meerut, and he has a very relevant practical tip for us. On to you, Dr. Shishir. Can you, yes, unmute. Yeah.
Thank you. Thank you so much, Dr. Chitra. I feel honored for this presentation here. Thank you so much. I'll share the screen.
Flip technique for an inverted IOL during cataract surgery. Sometimes while doing cataract surgery, inserting the IOL, we are faced with a peculiar situation like this, wherein the intraocular lens, it opens in an inverted or an upside down position, a reverse S configuration. The surgeon is in a dilemma as to what to do, that he may not create further complications. We fill the entire chamber with viscoelastic and use two instruments through the two side ports, either two Sinskey hooks or dialers, or phaco choppers. If you have those handy, you carefully flip the IOL and put it back into the capsular bag, and the trailing haptic is dialed back into position into the capsular bag. So it's a very simple, easy technique, a very complication-free technique. Here I demonstrate another case, a mature cataract in a busy OT, and we see the same thing happened in this case. As we insert the IOL, it opened in a reverse fashion and into the anterior chamber, in fact. So there's really no need to panic. You fill the anterior chamber fully with viscoelastic that you don't damage the endothelium. You have enough space to flip the IOL. You first, with the help of the dialer, push the leading haptic into the capsular bag and the IOL optic as well. And then you would use both the instruments in two hands through the side ports to flip the IOL. You have to be careful that you be away from the posterior capsule and yet be distant from the corneal endothelium as well, that you don't damage these two organs. And you flip this IOL into the capsular bag. Another third case wherein this hydrophilic lens had opened up in a reverse fashion in the capsular bag. You fill the capsular bag with viscoelastic and with two instruments, gently flip the IOL, being away from the posterior capsule. You have to be careful you don't damage the optic of the IOL as well, using both the instruments away from the center of the optic. So the important thing is correct loading of the IOL. A faulty loading technique also causes an upside down IOL opening inside the eye. And then a handy thing would be to use your left hand, a dialer in the left hand, when you insert the IOL, to properly guide the IOL, and in case it is opening in a reverse fashion, it can be properly oriented. Here in another case, doing the same, using the left hand to guide the IOL as it unfolds into the capsular bag, that such mishap does not occur. Thank you.
Thank you very much, Dr. Shishir. Again, very practical tips you have told us. I think the main message here is, even if this IOL were to unfold into the AC, your message is that you inflate the bag and ensure that the IOL is goes into the capsular bag and then you reverse it in the inflated capsular bag. So, and of course, the faulty technique of loading. Anything else expert panel would like to add? And in this context, I also wanted any of you who are doing hydroimplantation, what would your tip be in this? Yes, yes, Dr. Kamal and Dr. Vavikar, we will hear you both. Unmute yourself, Dr. Kamal.
Okay.
I am. Can you hear me now?
Yes, yes.
Okay. I think beautifully managed, Shishir. The game could be different if it was a hydrophobic lens. It could be slightly difficult in those situations because the loop tends to be a little rigid, and when it swings straight. These loops are slightly softer. What I would like to say is when you're having the same situation with the hydrophobic lens, it's a good idea to first backfold the haptic, which is going to swing, backfold with one hand, and then give it a flip. So the one which is there in the bag usually never will cause a problem. You have to make sure that the bag is well distended with viscoelastic. A low distended bag or a loose bag is prone for tears, but a distended bag, stretched bag would not tear. So the trailing group in this situation, which is there on the iris in a hydrophobic lens, can be backfolded and rotated, number one. As Dr. Chitra asked me, I do nearly 100% of my cases on hydroimplantation. And I've had these situations. I've got at least 20 such videos where in the hydroimplantation, this has happened. Now, the trick could be, again, depending on the lens I'm using. If it's a hydrophilic lens, I can still go ahead and back rotate it even when I'm on the hydroinflation mode. But in case it's a hydrophobic lens, and especially a lens which is a slow opening lens like Envista, which is far more rigid, very sharp edges, there I would probably want to withdraw my hydroimplantation, push in some viscoelastic and take some time, but make sure I do it fast before the lens opens completely. Because some of the slower opening lenses give you that leeway of, maybe 8 to 12 seconds before they open up. So if you could just manage to do that before that, but I use, most of the times I use a hydroimplantation, and I feel it saves a lot of time, no IOPs, no tasks, no pigments, no retained viscoelastic. But yes, you demonstrated it beautifully. Do the backflip technique, but in the hydrophobic, it's a good idea to backfold the loop and then do it.
Dr. Vavikar, yes?
We need to first understand why the lens unfolds upside down. Suppose the lens is folded equally in the cartridge, it will unfold like this. But suppose one side is folded less than the other side, the lens tends to open on the side where it is folded less. So that's why we have to ensure that it is folded properly. Now, unfortunately, you have a situation where one side is folded less. In that, it is very important that we rotate the entire injector in the opposite direction so that the lens unfolds horizontally in the entry chamber. So if we do that, there is no need of rotating the lens in the entry chamber. Plus, we also have a dialer. In case it is opening in the opposite direction, you have a dialer in the other end. You can just push the upper edge, upper part of the lens in the opposite direction, and you will have it properly positioned.
Right, so you have to rotate your hand as well if you are seeing that it is unfolding in the wrong direction, and the dialer in the left hand. That is right.
Thank you.
One comment, Dr. Shishir. I mean, these were all hydrophilic lenses?
These were hydrophilic lenses, yes.
Okay, these are all biconvex, biaspheric lenses. I agree with the comments made and also your technique of rotation. Of course, there could be minor variations, but it wouldn't have made one difference to the patient if you had just left it like that. Because this would make a difference when there is optic-haptic angulation, 7-10 degrees, when the position of the optics will change. If it's a multifocal or a toric lens, or if it's a aspheric lens like the Alcon lenses or the Technis lenses, where the asphericity is on one surface. But for the lenses that you have used, even if the lens had, because these do not have any optic-haptic angulation, there's the asphericity is distributed on both surfaces, and it's not a toric or a multifocal. Even if you had left the lens like that, it's not a good idea, but it's not as if the square edge or the posterior square edge is on one side alone. It's both anterior and posterior. Even if you had just left the lens as it is, it would have given you exactly the same results.
I'm going to go on to our next speaker, and we might have to be a little brief in our discussions now. We are a little short of time.